Very good afternoon. So I'll be speaking about intraocular pressure and gonioscopy. So we all know that intraocular pressure is a risk factor for glaucoma. It has been causatively linked not only to the development of glaucoma, but also with progression of glaucoma. Statistically, elevated intraocular pressure does not equate with the diagnosis of glaucoma. So it does not always mean that there's glaucoma. And conversely, we know that normal intraocular pressure does not exclude the diagnosis of glaucoma. So, but as the intraocular pressure increases, the prevalence, the incidence of glaucoma also does increase. Studies have also shown that a true causal relationship does exist because they have shown that lowering the intraocular pressure can slow or prevent progression of glaucoma. Intraocular pressure still remains the only modifiable variable that we use to prevent or delay progression. A target intraocular pressure is set in the management, hoping that attaining this pressure in the management will slow or halt the disease. The various factors that influence intraocular pressure: a thick cornea leads to overestimation and a thin cornea leads to underestimation. Valsalva maneuvers, postural changes, systemic hypotension, respiration, circadian rhythm, all these can influence the intraocular pressure. So why do we see diurnal variation in the intraocular pressure? Can one of the postgraduates answer?
Why do we see diurnal variation? Anyone? So why does it happen?
Yeah. So the rate of aqueous humor formation itself is twice as high during the day as at night because of the endogenous catecholamines. Higher fluctuation is seen in patients who have glaucoma and in those eyes which have progressive visual field loss as versus those with stable fields. Now coming to the measurement of intraocular pressures, the measurement is done by instruments called tonometers, and these are based on three principles: indentation, applanation, and contour matching. Indentation, prototype of which is Schiot's; applanation, prototype is the Goldman; contour matching is the dynamic contour tonometer, the Pascal's DCT. There are a large number of tonometers that are available, and I obviously can't be covering all of them. I'll focus mostly on the Goldman tonometer, which is the most commonly used. So which would be the most accurate way to measure intraocular pressure? So the best way is to cannulate the eye and directly measure the intraocular pressure either by a water column or by a pressure gauge. Obviously, this is not very practical. All other methods that we use are indirect ways of checking the intraocular pressure. So coming to Goldman tonometry, it continues to be the standard method of measuring pressures, and it's the most commonly used. It was introduced by Goldman in '54. Here you're using a variable force, and the area of applanation is a fixed area. It applies the Imbert-Fix law, which states that for a very thin walled sphere, which is perfectly elastic and dry, the internal pressure, so here it is the pressure inside the eye, is equal to the force that's applied per unit area of applanation. So GAT can be influenced by corneal thickness, curvature of the cornea, the structure or the biomechanical properties of the cornea, as well as the axial length. Now there's no nomogram which can actually convert GAT and CCT into true IOP, so they're best treated as two independent risk factors. And studies now and engineering models have suggested that the material properties of the cornea, that's the viscoelastic properties, affect GAT much more than CCT. So coming to the procedure itself, you anesthetize the cornea, apply fluorescein. It's very important to set the correct eye height, so the lateral canthus is at the level, at the black mark on the slit lamp. The head and the chin should be firmly placed against the rest, and the patient must look straight forward. You could use a small fixing light if you want to. The patient is told to keep his eyes wide open. So the trick is to tell the patient to keep the other eye wide open. So the patient is generally a little in awe because he sees this blue light coming close to the cornea. So tell him to keep the other eye open. Automatically this eye is open. You could also use your fingers to splay the eyelids open. Just make sure that you don't apply pressure on the lids. And at the same time, you can also feel the lids. Sometimes if you see a lot of tension, you just tell them to relax, because then you don't want abnormally high pressure readings. So you keep the magnification at 10x, the illumination is at medium intensity, you have the cobalt blue filter in. The slit diaphragm is wide as well as fully open. The width as well as the height are at the maximum. The sensor arm is snapped into place so that the axis of the prism and your microscope are aligned. The measuring drum is set at 1, and the angle between the illumination and the microscope is around 60 degrees. So you first ask the patient to blink so that the tear film is spread. You move the slit lamp close so that the prism comes in contact with the center of the cornea. You then see the bluish glow at the limbus. Once you see this, till then you're seeing outside the microscope. Once you see the bluish glow at the limbus, you look into the microscope, through the microscope, and you see the pulsation of the semicircular bands. So now you're looking through the microscope to look at the circular bands. So you adjust the slit lamp till the two semicircles are of similar size and they're seen exactly in the center. Now you turn the drum until the inner border of the fluorescent bands just touch. When the eye pulsates, these semicircles should just cross each other, and then the value on the drum is multiplied by 10 to give the pressure in millimeters. So for example here, this would be 32 millimeters of mercury. So here you're seeing 3 pictures here. Is any of these correct? Which one of these is right? None. So in the first 2, you need to increase the pressure. In the last one, you have gone beyond the pressure reading. So this is the perfect point of applanation. So if you see something like this, what's wrong with the first one? So it's too wide. So you probably have too much fluorescent. You need to pull back the prism, wipe it, and then try again. In the second one, it is too thin. So you need to either apply some more fluorescent or ask the patient to blink. In the third one, you have gone close to the cornea, but the patient would have then moved back. His head has gone back, and so you really don't see any of the Myers. Sometimes the patient is not sitting stable. If the height of the slit lamp is not adjusted, then he may be moving backward and forward. And so you see that the Myers are not stable, and as you turn the drum, you see that there is no corresponding movement of the drum to the semicircles. So then you need to make sure that the patient is sitting correctly and then check the pressures. In the last one, you have moved far too forward, and so then you need to pull the prism back till you see the pulsations and the correct configuration. So here you are in the top 2 figures, you see that the fluorescent rings are not seen, so you have not centered it right. In the top 2, you need to move it to the right. In the bottom 2, you need to move it to the left. Similarly, in this, you need to move the prism upwards to get the Myers in the center. So when do you get falsely low pressures? If there's too little fluorescent, if there's thin cornea, if there's corneal edema with rule astigmatism, if you've kept the contact for too long, or if you've repeatedly tried to take the pressure, if you check pressures after gonioscopy, your pressures may be wrong. Falsely high pressures, when there's too much fluorescent, thick cornea, just the opposite of whatever I've been telling. So in an eye which has high astigmatism, say if somebody has -5 into 120 degrees, then you keep this red mark that is seen here on the prism, you keep it at 120 degrees and take the readings, you're likely to get a more accurate reading. Now calibrating the prism is very important. So here you can do it at 0, 2 and 6 grams. At 0, you really don't need to keep any additional weight. You just move it 0.5 millimeters below and the prism moves towards you. If you move it in the opposite direction, it moves towards the patient. The same thing can be done using the weight. So here it is at 2 and 6. So this is how the weight is placed at the side of the instrument. It's kept in place. The longer arm of this should always be towards the examiner. So again, you move the dial both less by 0.5 and more by 0.5, and you see the bobbing of the prism. Perkins is useful in a supine position. Toner pen is a handheld device which, because of its small applanation area, is useful in the presence of corneal irregularities. The Pascal DCT works on the principle of contour matching, again useful when there's corneal aberrations or it's very insignificantly affected by the corneal thickness. Pneumotonometry also is a high displacement tonometer, and the measurements are independent of CCT, again useful post-LASIK eyes. Non-contact, there is no contact, there's no risk of corneal aberration. A non-optical staff can do this. However, it is not very accurate, and the aerosol which is generates can potentially spread infectious agents. Now, similar to the ORA and the Corvus are 2 new instruments which give us the corneal hysteresis, which is a new, relatively new concept wherein the biomechanical properties of the cornea are measured and a true intraocular pressure is given irrespective of the biomechanical properties of the cornea. So in eyes that have corneal edema, significant surface irregularity or scarring or a recent corneal grafts, the instruments that would be useful would be pneumotonometry, a tonometer, or a DCT. In children, in an older child, you can use Perkins. In younger children, eye care, which works on the principle of rebound tonometry or tonopen, is useful. Post-keratorefractive surgery, the DCT, ORA, or the Corvus would be useful. In a supine position, Perkins, pneumotonometer. Less accurate but more practical to use would be the tonopen. In an eye which has a K-Pro, you could not use any of these instruments, and that's when you would either use palpation or a transpalpebral tonometer. Coming to gonioscopy, it allows us to visualize and examine the iridocorneal angle. The trabecular meshwork we know lies in the angle, and it is responsible for 90% of the aqueous outflow. So it's critical for us to evaluate this area in all forms of glaucoma, both the primary as well as secondary. It provides clues about the mechanism of glaucoma, which in turn guides management strategies. So in whom would we like to do gonioscopy? Ideally, we would like to do it in all patients, which practically may or may not be possible. So then you need to do it in every glaucoma suspect, a patient who is at risk of developing glaucoma, and definitely, obviously, in a glaucoma patient. If you see a new vessel of the iris, if you see a patient with uveitis, if a patient gives history of blunt trauma, if you see PXF, PDS, or you want to do a trabeculoplasty, you want to assess the stoma post-trap, all this you definitely need to do gonioscopy. So if you look at the angle here, so this is the area of interest for us. That area which is shown now in the arrow mark is the termination of the Descemet's membrane, which gives us the Schwall baseline. The next one is the trabecular meshwork. Below that is the scleral spur, and the small area that you see below the scleral spur is the face of the ciliary body which is seen. So these are the structures that you see on in a normal angle. The Schlemm's canal is not normally visualized unless it is filled by blood. So the situation when it may be filled by blood is maybe if you're pressing too much on the eye, or if there's hypotony, or in conditions like a carotid cavernous fistula. So this is the actual picture. So the first arrow mark there shows the pigmentation on Schwall baseline. So Schwall baseline itself is a simply white line. So if you see pigment, then you might see a pigmentation which is like this. So this pigmentation is usually like a salt and pepper, not a uniform pigmentation, which is what is seen on the trabecular meshwork. So the next area that you see is the pigmented part of trabecular meshwork, and between these two, the white area which is seen is the anterior non-pigmented trabecular meshwork. The next one is the scleral spur there, and the last small area that you see there is the ciliary body band. Now, why don't we see the normal angle structures? Because the light which comes from the angle gets reflected back into the eye, and so you need to use a contact lens to visualize the angle. There are two types of lenses, the direct and the indirect lenses. This is an example of a direct lens. The curvature of the lens is quite steep, and so the light which comes from the angle is directly seen by the eye. In indirect gonioscopy, the light is reflected off a mirror, which the observer then sees the angle through the mirror. So what are the lenses which we commonly use in the clinic? Which of these lenses do we use in the clinics? Anybody? Direct or indirect? Yeah. So indirect lenses are what we commonly use in the clinics. And where would we use direct lenses? So you use it mostly in the operation theater. So the direct lenses are useful for performing surgical procedures. It's advantageous because you're getting a direct view. The orientation is very easy. You have to use the operating microscope to view the angle. So indirect lenses in the clinic are of two types. You have the 4-mirror lenses and you have the Goldman lenses. Examples of the 4-mirror, you have the Posner Zeiss and the Sussman. Goldman 3, 2 or 1 mirror lenses. Now which of these lenses would you prefer to use, and why would you prefer to use this? 4-mirror, yes. Why? Okay, all 4 angles can be seen. Anything else? Yeah, so one of the most important things is that you can do indentation gonioscopy with these lenses. You can have a simultaneous viewing of all the quadrants, and you don't require a viscous coupling agent with the 4 mirror lenses. Now, why is it that we can do indentation gonioscopy only with the 4 mirror lenses? What feature in the lens makes it? Yes. So if you see, the radius of curvature is more. It's a shallow kind of surface, and the diameter is lesser than that of the cornea. So you can indent, you can actually press on the cornea, which pushes the aqueous to the angle, so it can open up a closed angle if it is appositional closure. If it is closed by synovial closure, then it does not open the angle, which is why it does helps us to differentiate between a appositionally closed angle versus a synovial or a permanent closure. And this is useful for us in the management of the patient. So it is very, very critical for us to use these instruments for the management of glaucoma. So the disadvantage with the 4 mirror is that you have a mirror image. So you need to learn a little bit to how you view. It's more difficult in the beginning, and it is easy to inadvertently apply excessive pressure and falsely open up. So you need to be very gentle when you do the procedure. Coming to the actual procedure, you need to first do a thorough slit lamp before you actually come to gonioscopy. Finish your tonometry and then go to gonioscopy. So the procedure again, you anesthetize the cornea. Position at the slit lamp is, again, like I said, the lateral canthus is at the mark. The eye should be in primary position. Make sure you have an elbow support so that you can hold the lens comfortably. Dim the room lights. Hold the lens with the 3 fingers, the first 3 fingers, your index, thumb, and your middle finger. The other 2 fingers are braced against the patient's cheek, and your right hand would then be free to operate the slit lamp. You don't need a coupling agent if you're using a 4 mirror. However, if you're using a Goldman, you would require. The lens, like I said, has to be applied with a very light touch. Initially, you do the entire examination in low illumination in the primary position to determine whether the angle is occludable or not. Once that has been done, you can use bright illumination to look for any abnormalities in the angle. So during the procedure, again, use a low height of the beam so that you don't cross the pupillary area, constrict the pupil, and then falsely open up the angle. So what's this corneal wedge? So if you make a very thin slit beam and pass it through the cornea, because the cornea is a transparent structure, you see both the anterior and the posterior surface of the cornea. And when the cornea changes to the sclera, it collapses because the sclera is opaque. You start seeing a single. So you can see this point here where the wedge is collapsing. Where this point intersects is the Schwalbe's line, because that's the termination of your Descemet's membrane. So these are best identified in the superior and the inferior mirror. Now if you see this angle, is this an open angle? Okay, so once you do indentation, now you can see that what may have appeared to be the open angle on the left, now you can see that there is one pigmented line on top and a second pigmented line below, which is your trabecular meshwork. So this is the reason why you need to do indentation gonioscopy, because you don't want to falsely label these as open angles. So again, your wedge, corneal wedge also would help in this kind of identification. So the arrow mark there shows the trabecular meshwork, and the pigmentation above is the pigmentation on Schwalbe's line. The second thing is to learn how to orient. So if you see a lesion in your mirror, you need to localize the lesion. So in the diagram on the left, the mirror at 12 o'clock, you're seeing a lesion in the blue square there. So where do you think the lesion is actually in the eye? It would be at around 5 o'clock. So remember that it's a mirror image, it is not at 7 o'clock, okay? So this is how it is. So what is at 1 would be at 5. So what is at 2 is at 6, and opposite. So if you find it difficult, the best thing is to bring the lesion into the center of your gonio mirror. So 6 clock hours apart, you will know that the lesion is at that point. Now if you're using a gonio mirror and this area of red, you're seeing the area of PAS. So where exactly is the area of PAS in the patient's eye? What would be the extent of PAS? Right, so that would be the extent of the PAS. So 6 to 9 o'clock is the area of synovial closure. So the grading systems, we know there are multiple. I think most standard textbooks would tell this. So in SHE system, a fully wide open is grade 0, whereas it's the opposite with Schaeffer's. Spatz is more exhaustive. It tells you about the iris configuration, the angle width, as well as the level of iris insertion, and also grades the pigmentation. Now, what is important when you do gonioscopy at the end of your doing the procedure, you should be able to answer these two questions. Is this angle occludable? Is there any abnormality in the angle? So then most of the reason why you did the gonioscopy is taken care of. So you can actually describe what you see. So in the superior quadrant, the structures that are seen. So you see it up to the scleral spur. So the maximum or the most posterior structure that you see, and then describe what is the configuration of the iris. You saw a convex iris. What was the pigmentation? Was it 2+, 4+? Did you see any abnormal structures like a new vessel? So describe that, and exactly what point did you see a PAS? Was it a point PAS? Was it a broad area? Describe that. So here, what do you, I'll just give a few examples. What are you seeing here? That's neovascularization in the angle in a patient with neovascular glaucoma. What you're seeing here? A broad ciliary body band, so that's angle recession. What would this be? So that's a ball of pigment. So many times if there's an old injury and the hemorrhage has happened or hyphema has happened long back, you might just see a ball of heme in the angle, which is suggestive. You can also see some moment of recession in this same picture. So this would be an Axenfield's anomaly. So you see these multiple fine iris processes which are attached to a prominent Schwall baseline. Here you're seeing a foreign body in the angle. And that's the inflammatory membrane which you can see curled up in the angle in a patient with acute anterior uveitis. What would this be? That's lens material in the angle. That's a haptic that you can see going through the iris. It's sitting in the angle and you can see the increased pigmentation. The pigmentation is almost 4+. So in these eyes, pseudophakic eyes, unilateral glaucoma, unless you do a gonioscopy, you will not be able to find out what is the cause why this patient is having increased pressure. So you can put any number of medications, the pressures may not settle down unless you treat the primary cause, whatever is causing the glaucoma. So what are the other causes where you can have increased angle pigmentation? So pseudoexfoliation, pigment dispersion, post-angle closure attacks, trauma, surgery, uveitis, host of others where you can see. Also in evaluating post-surgery, you can see the express shunt here. A word about anterior segment imaging. UBM and AIOC2019, you should remember, are not substitutes for gonioscopy. They cannot differentiate appositional closure from synovial closure. You cannot see new vessels, you cannot see the pigmentation of the trabecular meshwork, you cannot see pseudoexfoliation material and a host of these things with any of these imaging techniques. So are they useful? Yes, they are useful. They might help you in determining the mechanism of glaucoma. They help in documenting the dynamics of the anterior chamber. It helps in quantitative volumetric measurements which are repeatable. Evaluation behind the iris and ciliary body, which cannot be seen either at the slit lamp or with gonioscopy, is aided by these instruments. So they are useful adjuncts to gonioscopy in select patients. Thank you.
Thank you, Dr.